Morning, Monday morning again, 10 o'clock. Welcome back, everybody. Just a quick plug before we get going. It's really mad actually because over the last sort of 10 years, I've been at therapy. Yeah, about 10 years been at Therapy Expo, and before that, I used to do a lot with the fitness industry. So was at FitPro, and now they don't do. I don't think they do FitPro anymore, but we do Elevate now, or the old Copa show. So I've been asked to present there, and yeah, loads of my old fitness mates have got in touch. So it's really, it's going to hopefully be a really good session. DNM2, knackered. Yeah, I bet you are. Yeah, yeah. It's a long old 3 days learning all those techniques, and the chat. There was plenty of chat. Yeah, a lot of theory on that one. Sarah, good morning. Sorry, I've just moved my where my comments come in, so they're down here. So if I'm looking here, then yeah. Yeah, just want to make sure everybody else can hear me okay. If you want to give me can't hear anything, is everybody else okay? Can everybody else hear, or is it just Penny? If you could just let me know, that'd be great. It's all looking okay on my side. Morning, Neil. Morning. Morning, Becky. Morning, Neil. Yep, all good. Okay, I'm afraid it might be you, Penny. Let me just put this in there. Bear with me a second. Cool. Okay, cool. Yeah. Yeah, good. Okay, good. So hopefully Penny will get her sound sorted. Yeah, so if you are in London, it's free. If you're in London and you've got nothing better to do, nothing better to do, then you can listen to me waffle on about anatomical variations. And yeah, so in the fitness industry, there's a big kind of emphasis on correct technique, and yeah, the more and more you kind of learn about anatomical variations, you realize that people have to move in different ways. So yeah, that's what my talk is going to be on. So if you're in London this week, Wednesday, Thursday, free event at the Excel, and yeah, there's quite a few good speakers there. Cool. Right, let's get going. So hopefully this is the right one. Yeah, so we're going to be building on the stuff we did with the sacral plexus. So last week, oh cool, good, glad you got it, Penny, good. So yeah, last week we started to introduce the tracts in the spinal cord. And the various places where they travel, and we're going to add another layer onto that today. But before we do that, we're going to have a look at some of the plexus around the lumbar plexus. So we've had a look at the sacral plexus already. When we get higher up, there's no thoracic plexus because each of the nerves comes out in between the ribs. But in the cervicals, there's a plexus, and then there's another kind of plexus of nerves above that as well. So we'll kind of add these on as we go. So let me just show you a bit of an intro here. Yeah, here we go. So we've got, just make sure that's working. So this, if you've been with me for quite a while, this might give you a few nightmares. This is the cervical plexus, and it's probably one of the most difficult ones to understand because there's stuff going to the back, there's stuff in the middle, and there's bits joining on from all different areas. And then it's split up into roots and trunks and divisions and cords. So the cervical plexus is by far one of the most complicated out of all of them. So let me just get rid of that ticker so you can read everything. So yeah, basically axons, and we should understand this terminology now, hopefully. So axons, which are the main bits of the nerves from the anterior rami of spinal nerves. So we had a look at that last week. So those are the bits that come out the front. and rami means branches, so it's the front branches. They don't just go directly into the body structures, they supply, apart from the thoracics, they don't go directly into the body structures, they supply. So these spinal nerves form networks within the adjacent spinal nerves, and these are called plexus. So it doesn't just go, that one goes to the bicep, that one goes to the brachioradialis, that one goes to the hamstrings or whatever. There's contributions of nerve impulses from different levels of the spinal cord, and that's really sometimes it's only one, but so it depends on the whether it's sensory, motor, and what part of the body. But quite often there's overlap, and that really makes good sense, because if you have an injury to a specific area and that area supplied a specific muscle and that was the only supply, then that muscle wouldn't be able to work. Or if it was to a specific gland or a specific organ, then the organ wouldn't be able to function. So we've got these contributions of nerve impulses from different parts of the nerve roots. And those all come from different parts within the spinal cord. So we've got shared distribution going to the muscles, and we've also got shared information coming back in. So, for example, if you imagine my fingers were the that one be easier, but were the layers of the thoracic spine. So imagine that one was T4, that one T5, and that one T6, and it's coming out between the ribs. Okay, so let's say it's the sensory part, so the skin comes back in through T5, I think so, T4, T5, T6. Now, T4 will provide sensation to the skin above it in a bit of T3, and below it as well, a bit of T5. And then T5 will supply a bit of T4 and T6, and then T6 will be a bit of T5 and T7. So there's an overlap of the sensation of the skin. So if you have a problem with one of the nerves, then one of the other nerves will be able to pick it up. It might feel a bit weird, but the sensation will still be there. So that makes complete sense, and that's why these theory behind why these plexus have been created. So after the spinal nerves have weaved together to form a plexus, and plexus means plait. Yeah, so if you think about plaiting hair, that's what plexus means. The nerves then emerge from the distal ends of the plexus, and they form the main nerves of the body, and these are the ones that you usually know the names of. So, for example, here in the brachial plexus, which is the one coming out of your neck and supplies all your arms, you might have heard of musculocutaneous nerve, axillary nerve, median nerve. You might have heard of those already, but they come from different nerve roots. So, for example, the median nerve comes from all of them, C5 all the way down to T1. There's a contribution from each level for the median nerve. Okay. Good morning, Julie. Good to see you in this morning. Cool. So let's have a look at the lumbar plexus, and this will finish off the lumbar sacral plexus, because we did the sacrum before. So now is the time, if you want to kind of put all this together, and you can get your skeletons, you can get your pipe cleaners, and you can put the pipe cleaners through the nerve root or through those transverse foramen where the nerves come out, and then you can start joining things together and having a bit of fun. And hopefully making it will help you make sense of where things go from and to. Cool. Now, it's always the rude acronyms that we remember. So the lumbar plexus is I twice. So the letter I twice, get laid on Fridays. Okay, so this is a rude way of remembering the lumbar plexus. And like I said, it's always the rude ones that you remember. So I twice is this nerve here. So the iliohypogastric, that rolls off the tongue, and ilioinguinal or ilioinguinal. And we've had a look at these before when we were looking at the pelvic floor and the region around the inguinal ligament and the abdomen area as well. So we've been introduced to these nerves a little bit before. We've also been introduced to this one, the genitofemoral nerve. So this one supplies the cremaster muscle and the skin over the anterior surface of the thigh, the scrotum, and the labia majora. So obviously, depending on the sex, it would still supply the same region, but obviously different parts of the genitalia. And we've been introduced to that before as well. But if you have a look where these come from high up in the lumbars. Okay. Um, yeah. This. Yeah. It's definitely not my one of my phrases. This one, but there we go. So iliohypogastric, anterior lateral abdominal wall and skin of the inferior abdomen and buttock. So if you have weird sensations in your buttock and around the lower part of the abdomen, then it could be the cutaneous nerves that come from your lower back. Okay, so this might give you a few clues of some of the areas where you might need to assess. And it's funny because I kind of I learned these and then you, if you don't do them all the time, you forget them. And since doing all the DNM stuff and all of the cutaneous nerves and where they branch off and supply, it made me change my treatment for some of my patients. One guy that we were doing a lot of work with, like a piriformis type issue and that deep gluteal syndrome, and actually when we started to work into his lower back, that's when things started to improve. So working on that region specifically didn't really make much of a difference. So I thought, right, okay, where's the innovation for these areas? And then he had some real discomfort around that L1, L2 area. So we did a bit of treatment in there, and then that significantly affected his symptoms. Okay, so it's quite interesting, and this one as well. So the ilioinguinal muscles of the anterior lateral abdominal wall. So we've had a look at those before. Superior and medial aspects of the thigh, so kind of inner thigh, and then sensation into the penis, the scrotum, or the labia majora, or the pubic bone. So if you, I've had a few patients again that have come in really worried about having an inguinal hernia. Really worried about having testicular cancer because they're getting symptoms into their testicle, and then again, everything's been scanned, so we checked all the high level stuff first and make sure it's all clear. But then, actually, when we've worked into their upper lumbars, that's when things have started to improve. So there was some kind of, in my mind, the kind of reasoning behind it. There's some kind of irritation to this nerve that has caused an altered sensation for this particular patient that I'm talking about into the scrotum. So he was absolutely petrified. He had testicular cancer. So we made sure that all that was checked, and obviously not my remit. So I've sent him off to make sure he gets all the examinations. When it all came back clear, then we could start to work on some other reasons why I might be getting those symptoms. So these are really important areas with kind of sensation loss or weird sensations in the genitalia. And then you've got lateral cutaneous nerve. Now this is the skin over the lateral anterior and posterior aspects of the thigh. This is a classic that we've talked about this before. So where the lateral cutaneous nerve comes out is just underneath the inguinal ligament, and we've looked at this on previous videos. So that can get compressed if you wear a really tight belt. If you're a bit overweight and you sit a lot, and it kind of compresses that region, so it comes out just medial to your ASIS, just underneath that inguinal ligament. So it can get compressed there, and it will make the whole side of your thigh go numb. Right, and that's a real classic one there. The lateral cutaneous femoral, sometimes called lateral cutaneous femoral nerve. So it's on the outside of your thigh. So if anybody has a loss of sensation there, it can be a compression point on the ASIS, or it could be something coming from the lumbar spine as well, and that emerges from L2, L3. Okay, anything adductor, and again we've covered this one before. We've had a look at these nerves before. L2 to L4, obturator nerve. So that's the nerve that comes out of the obturator foramen. So when we looked at the hip, we covered that nerve in some detail, and the femoral as well. We've done that one too. Okay, and these are the flexor muscles of the hip and the extensors of the knee. So bringing your knee up towards your chest and then straightening your knee. Okay, so that's what that one does. It also supplies the medial aspect of the leg and the foot, so the inside of the leg and the foot, and that's cutaneous nerve, the saphenous nerve. Okay, so it goes all the way down there. So all of these come from your lumbar spine, and can all, a lot of them are mixed nerves, so they do a little bit of motor and a little bit of sensory as well. So, so for example, abdominal wall, muscles of the abdominal wall again, the cremaster muscle. So that I don't know whether you remember, but we looked at something called the cremaster reflex. So if you lightly touch the inside of someone's thigh, then as a reflex action, well, say someone's a male's thigh, and then as a reflex action, usually the testicles draw up into the body, and that is called the cremaster reflex. Okay, so that's again maybe out of your remit, not really an area that you deal with, but in terms of pelvic health, that's the kind of thing that they would check. Okay, so let's have a look at the pathway of all of these things and how they all connect to each other. So we've got where were we? Let me just move me out of the way. So we've got a similar kind of setup to what we were talking about with the brachial plexus, where you've got some that emerge from the back and so, or go backwards, and some that come forwards. So we've got anterior divisions, which are the red ones, and then posterior divisions, which are the blue. Okay, so if you have a look here, the L1 supplies iliohypogastric. Okay, the L1 also supplies ilioinguinal. Okay, so that's I twice. Okay, that's those two there. And then we've got a contribution from L1 and L2 for this genitofemoral nerve here. Okay, so you can see the branch coming off here, and then that comes down there. So when you're doing your pipe cleaners, you'd need a branch coming off of L1 and L2, joining those together, and then that's your genitofemoral nerve. Okay, L2, L3 is the lateral cutaneous. See coming off here and here. This is a lot simpler than some of the other plexus that we've seen. The femoral is obviously quite a does quite a lot of work. So it's got contributions from several nerve roots. So we've got L2, L3, and L4, all contributing towards the femoral nerve, and then L2, 3, 4 for your adductor muscles as well, and the sensation on the inside of your thigh, and that's your obturator nerve. Okay, so it's like, oh, is that it? That's good. Okay, and when you combine the lumbar and sacral together to get that whole picture of the lower limb, and if you have a look here, we've got the lumbar-sacral trunk, and that joins the top of the sacral plexus, and we've covered that previously. Okay, so and that kind of finishes off that lumbar sacral region. Okay, so going to talk a little bit about some clinical issues around this area. So we've talked about cutaneous nerves before, and cutaneous basically means to do with the skin. So you might have heard of subcutaneous fat, which is the fat underneath the skin. So cutaneous nerves are in the skin. They're around the joints, and they are they're getting sensation. Basically, they're purely sensory nerves. So when we test sensory nerves, we are testing something called a dermatome. Okay, and yeah, I've covered this a little bit before, but not in any not in the detail that we're about to go into. So brace yourself. So derma means skin, and then a tome is a section. So there'll be a specific nerve root that will supply a there'll be a contribution of the sensation of a certain part of the skin. And remember, there is overlap. Yes, we've talked about that already. So it's not like, yeah, that bit's definitely there. There are some bits that are more common than others. And if you test a specific area, then it's very likely that is the nerve root that you're testing. Okay, and the dermatome. So yeah, if someone has a weird sensation in their skin, so a dermatome is an area of skin innervated by a single spinal cord level. Okay, and again, there's a bit bit of overlap, like I said. So we're going to have a look at this. Apologies for all the text, but you can pause this and read through it. I'm just going to pick out some key bits. So knowing which spinal cord segments supply each dermatome makes it possible to locate damaged regions of the spinal cord. So if someone has an injury to their back and they've got soreness in the back and they're getting numbness down their leg, then we can safely assume that there may be an issue. And now, depending on what level you're trained to, for some of you, it'd be like, well, I'm not even touching that. You need to go and get assessed. If you've got a higher level training, then you can do the testing to see if it is what you think it is, and assess the likelihood of whether there's an issue. Because sometimes people report weird sensations, but then when you test it, there aren't any weird sensations. There's nothing that we can detect from a clinical picture. So it moves the likelihood of there being a nerve irritation or nerve damage lower down the list. Okay. So if the skin in a particular region is stimulated, but the sensation is not perceived, then the nerve supplying that dermatome may be damaged. Okay. So basically the signal, and we looked at this last week, the signal's not getting through. Okay. So it could be on the skin, along the axon, so as it's traveling towards the spinal cord, or it could be where it goes in at the spinal cord, or it could be somewhere in the spinal cord or the brain. So it's that whole loop, everything there will give you different symptoms depending on where the problem is. Okay. So in regions where the overlap is considerable, then that little loss of sensation may result if only one of the cutaneous nerves supplying that area is damaged, and that's what we were talking about before. So if you've got, like I said, in the thoracics, you've got several layers that are contributing to each of those. You can lose T5, but still feel the skin over T5 because T4 and T6 will contribute to that area. Okay, or contribute to the sensation. So information about the innervation pattern of spinal nerves can also be used therapeutically. Cutting posterior roots or infusing local anesthetics can block pain either permanently or transiently. So we can use this, well, not we, but surgeons can, because the dermatomes overlap. Deliberate production of a region of complete anesthesia may require that at least 3 adjacent spinal nerves be cut or blocked by an anesthetic drug. So if you're having a nerve block, they will usually block out a section, because if they only did one, you'd still feel stuff. Yeah. So it can be used therapeutically in that sense. Okay, as a part of a medical procedure. So this is a kind of simplified version. So C7 is supplies the skin of your middle finger. So and again, apologies. It's not rude. This one is just well, it kind of is rude. But you've got six shooter and then 7 up. Okay, that would be a screenshot. So that's how I remember C6 and C7. Okay, so 6 shooter, so that the C6 supplies your thumb and this finger, and then C7 is your middle finger. All right, so basically that region there is supplied by C7. So if you touch something on your middle finger, then the sensory receptors in that area will send nerve impulses if the threshold is at a high enough level, and it will go into your C7 nerve root to the dorsal aspect, which is what we looked at last week, and then it will go through a specific tract, depending on what the sensation is, up the spinal cord into the relevant part of your brain. And then your brain will go, you've just been touched on your middle finger. Okay, and there'll be different pathways used depending on the sensation that you feel. So if it's something hot, something different will happen than if it's a light touch with a feather. Okay, you will still detect both sensations, but your body will use different pathways to get that information to the brain so that your brain can work out what to do. Okay, so there are some things that are obviously put you in immediate danger of some kind of perceived damage. Yeah, so a threat. So it will move you out of the way really quickly. Sometimes, obviously with light touch, that can be the case. So there can be alterations in your sensation. But that's in a nutshell is kind of what's happening. And just had someone in clinic the other day talking about this, and I thought this is a really good way to show dermatomes. It's not a very nice condition to get, so the herpes zoster virus will give you shingles in adulthood. It's the chickenpox virus. So if you it lays dormant in your spinal nerve roots, and then when the infection is activated, it will then infect the sensory nerve, and you can see the distribution of that sensory nerve. Okay, so it's a really really good visual. Obviously, not a nice condition, but a good visual to show you where that sensory nerve goes, and it's usually around the thoracics that you will get it. Okay, so if you see anything going along the line of a dermatome and it looks a bit like that, then they may have shingles. Okay, and it's not always like that. I've had some weird ones in the past, but yeah, it gives you a good sense of the pathway of that sensory distribution. Cool. Okay, so how does all that come about then? Comes about by this. So I'm going to show you a couple of little slides, and then we'll show you a little video of hopefully trying to explain it so that we can see where everything comes from. So when you're an embryo, you look like this. So head here, spinal cord all along here. And remember we said your spinal cord fills your vertebral column when you are in the womb. Okay, and then as you develop, everything gets stretched, and that's where cauda equina comes from, your cauda equina. Interesting. Okay, so my husband, just moved that, has long COVID symptoms and hives flare up, whereas shingles were in the past. Yeah, it's fascinating, all that stuff. It kind of like makes sense when you understand how things distribute around the body. So yeah, so this is you as an embryo at 5 weeks, and already see these little bumps here. These are called somites. So these little bumps are the starting place for the innervation of your muscles, the innervation of your skin, the bones, the joints, everything. Okay, so they start as these like blobs on your back. Okay, now this is a really really detailed picture, but you only really need to focus on this bit here. Okay, so if we have a look here, we've got these things called mesoderms, and you might have heard me mentioning those. So we've got an endoderm, an ectoderm, and a mesoderm. So when you're an embryo, you've got all of these. You're basically 3 layers. Okay, and the middle layer is a mesoderm layer, and that middle layer, if we have a look at this this pathway of the mesoderm, because this is what we're interested in. So there's the somite. So those are those little blobs on the back that we just saw. And then those split into 2 main areas. And I'll show you a little video in a sec. So we've got a sclerotome and a dermomyotome. Okay, and we've already heard a little bit about this one. Okay, so dermomyotome is the sensation to your skin and your muscles. Okay, and then the myotome is the innervation of your muscles, so the movement of your muscles. So we've got the dermatome bit, which is the sensory part, and then the myotome bit, which is the motor part, and that all then feeds into all of the stuff we've been doing over the last few weeks. Okay, we don't really touch on this very much, but I just want to sow the seed for those of you that want to do a bit of investigation. If you've never heard of sclerotomes before, this is really interesting because they provide sensation and they build basically the building blocks of your vertebrae and ribs, your endothelial cells, your joints, and your tendons. So you can sometimes get sclerotomal referred pain. So if your lumbar spine hurts, then that section, which is the bone bit, so the sclerotome section, it can refer pain to parts that it's connected to, and this is sometimes why we get those weird sensations. So it's like sacroiliac joint issues and irritation to the sacroiliac joint can present like groin pain. It can present like buttock pain. Okay, So we can get these referred pains from the joints. Yeah, so and that's something that's not often discussed. We usually talk about dermatomes and myotomes, but not really the sclerotomes. And I think there's it's worth having a, and you can see the images of sclerotomal patterns. Okay, so you can have a look at those. So basically, what happens as we grow? So we've got the forming vertebra just here. This will be your the neural tube where your spinal cord will be, and then these are a bunch of cells whilst you are that 5-week-old fetus that will eventually develop into your muscles and your skin. Okay, so we've got these different layers here and here. And I'll show you this next picture because this will hopefully make things make sense. So there's your primitive spinal cord. There'll be a signal that will come off to go, right, okay, I need a bit of nerve tissue here to attach to this bit. So what happens is there's a gap that forms in the sclerotome, which is eventually your vertebra. Okay, and then through that gap will go a little bit of nerve tissue, and then that'll attach to your muscle in this example or your skin. And then as you develop, that nerve will then get pulled with the muscle as your arm grows and pulled with the skin as your skin grows. So this is why when you test different parts of the body, it refers back into the neck. Okay, because literally the spinal cord and the peripheral nerves have been dragged along as you grow. Okay, and the really interesting thing is when you are an embryo, you won't just have one of these nerves poking through. You'll have several that come through, and the nerve impulses will go through to that muscle. And then as you develop and as you grow and you're moving your arms and your legs around, some of those nerves will start to be used more than others. So it's a bit of a survival of the fittest. So that nerve then stays and it remains and it becomes your nerve. And the other nerves that we used to supply and help out, they die away. Okay, so then you're left with your nervous system. And this is why we get those variations in the nervous system, because sometimes you might have 2 sciatic nerves. Sometimes it might go through the muscle, sometimes it goes over the muscle, and it's all to do with embryology. Okay? And that's why everybody's different. So hopefully that makes all of that make sense as well. It's absolutely fascinating. So when you're doing testing of any kind of region of the body, if you imagine yourself as this little alien baby here, and you've got C4 coming there, C5 coming there, C6, C7, C8, T1, T2. So if you imagine you as a little blob with tiny little arms, so coming out of your neck will supply that bit, and then coming out of your neck will be the next bit, and then the next bit. Then as your arm grows, that all then gets stretched, and then when you stand, you don't stand with your arm out to the side. You have your arm down by your side. So that's why it looks weird when you look at the dermatome patterns, because they look all twisted, and it's because they get pulled and twisted as the nerve goes with the arm and the development of the arm or the development of the leg. Okay, so when we have a look at those dermatomal patterns, you'll see them all in lines, and then in the arms they twist around. But in the thorax, so this area here, because there's no limbs, they just stay in bands. Okay, they just go around the ribs, the intercostal nerves. Okay, so it's absolutely fascinating. So if you ever forget, you can't really do it with the legs, but if you ever forget the nerves for the arms, all you got to do is put your arm out by your side like that, and it literally goes C6, C7 in the middle, C8, T1 in that line. Okay, and that's the easy way to remember it. It's just that bit C6, middle bit C7, C8 and T1 is on the underside of the arm. Yeah, and again, there's going to be crossover between them, but on the whole, that is it. A little bit harder to do with the legs. If you can do the splits, then it's good. But yeah, you just have to remember where the patterns are for the legs. There are some variations in skin maps, like we talked about, but these dots here are from I think it's something like the American Neurological Society or something like that. But these are the standardized dots for testing dermatomes. Okay, so if I tested, let's say, end of your middle finger, that is C7. Kind of 95% of the time, that bit innervates C7. So if we have a look here, L2 is a big region. Look at all that there. But if you test there on the inner part of the thigh, that is L2, pretty much. Okay, so these maps give you a much more accurate measurement, and what they've done is they've done this over with hundreds of people and looked at the most common consistent points. Okay, cool. Okay, right. Let me just show you a little video because you've had enough of me warbling on. So hopefully you found it interesting. Let's have a look at this. Okay, cool. So this is a little video that was on YouTube, and then I've just added some bits to it. So this is to do with the somite. So let me just pause that there. So we've got loads of information going on here. Okay, so these are your 3 layers. So that's your outer layer there, your ectoderm. This is your endoderm, and your endoderm becomes your guts, basically. So it's like a big tube from your mouth to your anus, and then all of your everything gets stretched, and then it fills in all the gaps with all of your organs. It's just mental. Okay, so it becomes your trachea, and then into your stomach, and then the stomach then becomes the small intestine, then the large intestine, and then the anus. Okay, so and that all comes from that endoderm just there. Okay. What are the names of these maps? I've got it on a slide somewhere, Sarah. So it's something like the American Society of Neurological Disorders or something like that. But there's a specific paper I found them in. I've got the reference somewhere. I'll find it for you. I'll post it in the group. So so this layer here is endoderm, and that it becomes your gut tubes. This layer here is ectoderm, and that becomes your skin. And this middle layer here is mesoderm. Okay, and actually the endoderm, the ectoderm, this layer here, also joins in with your nervous system. And we've said this before. So the tissue that is your nerves is also derived from your skin. Okay, so they're basically connected, and this is why your skin is an extension of your nervous system. It all comes from embryology. So that this mesoderm layer is the middle layer, and we've got a sclerotomal layer. So this one here. So this one is the one that forms the bones and the cartilage and all that. And then we've got dermomyotome, which is this purple layer here, and that's your muscles and your just move me out of the way. Your muscles and your skin. Okay, so those are the 2 main parts of the mesoderm. Okay, the sclerotome and the dermomyotome. It's a lot of kind of heavy words, heavy language. So we're just going to add some more information in a second. I'll just move me down here. So there's your ectoderm layer, there's your endoderm layer, and each somite. So if we go back to this, so that's that original picture that I showed you. So each of these little blobs here, each of these somites is closely associated with a transverse segment of future spinal cord. Okay, so this here. Yeah, so each of these levels basically grows out and becomes other bits of your body. Okay, and those are called neuromeres. So if you want to have a look at that, then you can. Out of my scope, that one. So if you want to do a little bit more reading, then you can. Hopefully this hasn't paused. No, it's still going. Good. Yeah. So from each, just pause that there. So from each of these segments or neuromeres, motor and sensory nerve fibers of that particular spinal level will arise later during further development. So this is the bits that come out and then they join into the muscles or the skin. Okay, it's absolutely fascinating how this all happens. And if you Google embryology, then you should be able to come up with some like time-lapse videos of this stuff. So the dermatome and myotome also guide the migration of primitive neuronal fibers into the segments of the dermis, so into the skin, and the muscles of the body. Okay, so and that is this bit here. So this section is showing into the muscles, but it will be exactly the same for the skin as well. So from what we've done over previous weeks, these would be your ventral roots, and then coming back from the skin would be the dorsal roots. Okay, so those are the bits that we've seen before. Okay, and then there's a picture in a second of a dermatome map, which is what we've just been talking about, hopefully. Here we go. There it is. Okay, and there's your dermatome map. So you can see here in the thorax, it's all in a line because there's no limbs. Yeah. Whereas here in the limbs, they're all a bit twisted. Yeah. So you go, okay, why is C7 that way? And if you think about it, they're on that picture there. They're in the anatomical position, so they've got palms facing forward. But when you walk around and move, you don't walk in that way. You walk with your arms rotated inwards. So it looks a bit weird that C6 is here and C8 T1 is over this side. But actually, if you put your arm out by your side, it makes perfect sense because it's all in a line. Okay, and then similarly with the lower leg, look at all those variations. So it looks as if it's all twisted. But if you just put the legs out like doing the splits, then they would all pretty much be in line. Okay, and again, obviously with some crossover. So that's basically what's going on with our dermatomes and myotomes. So now we're going to bring it back into the spinal cord again, and just going to talk about tracts. So we introduced this a little bit before. What time is it? Yeah, 5 minutes, and then you can go and have a coffee. Another one. So the spinal cord has two principal functions in maintaining homeostasis, so a balance in the body. Okay, so we've got nerve impulse propagation, so basically sending nerve impulses, and then integration of information. And that's what it's all about. Okay, yeah, cool, yeah, good idea. Yeah, seen an image of dermatomes on all fours like a dog, which made more sense. Yep, that makes sense. Yeah, definitely. Yeah, we kind of twist as we develop. So that's a really good one. So we had a look at this last week. And we looked at, we mentioned the fact that there were these different zones within the grey and the white matter where there were pathways where the nerves then travel up and down the spinal cord, and these grey areas were ones that had more neurons in. Okay, so and that's the reason why they're grey, because it's dense. Okay, there's dense tissue there. So sensory input travels along these tracks towards the brain. Okay, so something you sense on your fingertips will come into a tract, in through the dorsal nerve root, and then up a tract, depending on which one it is, up towards a certain region of the brain, depending on what the sensation is. Motor impulses travel from the brain down towards the muscles or the organs. Okay, so they are either autonomic, so secretion of hormones or whatever it is, or voluntary. So you want to move a limb, so your brain moves the limb for you. The names of the tracks tell you which direction they go in. Okay, so anterior corticospinal tract. Anterior means at the front. Cortico is to do with the cerebral cortex in the brain, and spinal means spine. So basically, the anterior corticospinal tract is the tract at the front from the brain to the spine. So if it's from the brain to the spine, it has to be a motor tract. Yeah, it can't be sensory because it's going the wrong way. Yeah, so all of these long words, all of these weird words with this tracks, when you read them, you should be able to work out which way they go and which one's a motor and which one's a sensory. Okay, and there are specific pathways for each one. So our body is trying to maintain homeostasis. So we've got this sensory input coming in, and then we've got the motor output coming down. And the way to remember which ones do which is same Dave. Okay, so we've got two Daves here. Sense, if you think about SAME, so the sensory nerve is the afferent nerve, which means motor. Okay, sorry, sensory means afferent and motor means efferent. Okay, so same. sensory, afferent, motor, efferent. And then we've learned dorsal and ventral. So you're thinking, well, Jesus, which one's sensory, which one's motor? Dorsal is afferent, ventral is efferent. So these all mean exactly the same thing. So if you hear about a sensory nerve, SA, so same, that means it's an afferent nerve. If you hear of an afferent nerve, it's on the dorsal aspect of the spine. That's the easiest way to remember it. Okay, so same Dave. So sensory, afferent, motor, efferent, and then Dave, dorsal is afferent, ventral is efferent. And when you read literature, you read books, these words will be used interchangeably, and it gets very confusing. So yeah, if you can remember two David Beckhams, then hopefully that will help you out. Okay, so I'm just going to leave you with this. Because this will set us up nicely for next week. So this is the spinal cord cross section. We've seen all this before. We know that this bit must be sensory because there's the dorsal root ganglion. We know that this bit at the front must be motor. Okay, so this must be the anterior aspect here. This must be the dorsal aspect here. So these are the key tracts we're going to be looking at. So these are important tracts for neurological testing. The spinothalamic tract and the posterior column. Okay, so the posterior column is obviously at the back. This bit here. Okay, so the blue bits are the tracts that are receiving information from the body, sending it to the brain, and the red bits are receiving information from the brain, sending it down to the body. So these bits here. Okay, so we've got the lateral corticospinal tract, we've got the posterior column, and then the spinothalamic tract, which sometimes that's split up in different bits. Okay, so just sowing that seed, because we're going to have a look at what happens when you do reflex testing and what happens when it all goes wrong. So when people have strokes, people have problems with their spinal cord, or somebody has a problem with their muscle, and then depending on what symptoms they're getting and what responses they're getting, it will give you a good clue as to what you need to do. Okay, cool. Bit of a heavy one today. So yeah, Tristan, I hope you're all right after a few days of training, and then having that thrown in as well. If anybody's got any questions, because this is a heavy topic, if you want me to cover anything again because you're not quite sure, give us a shout in the group. Happy to do that. And otherwise, we're going to build on this next week, and we're going to go into reflex testing. If you don't want to post in the group because you're thinking I don't want to look silly, then please just message me privately, and I'll respond privately. Okay, cool. Well done, everyone. I will see you next week at 10 o'clock. See you then.